All right, with the osseous structures of the knee, we will be palpating starting with the distal femur, coming down the femur or inferior on the femur till we come to a bump on each side, being the the lateral epicondyle and the medial epicondyle of the femur. From that point, we will cross a little gap and come to a ridge along the tibia. And that ridge that we can palpate all around the sides and towards the front, it ends where the patellar ligament or patellar tendon is, and then it ends on the lateral and medial side where the lateral collateral ligament and medial collateral ligament begin. That is called the tibial plateau. Now, pushing into that tibial plateau, just above it, that is where your menisci lie, your lateral meniscus and your medial meniscus, the anterior horn of each. The coronary ligament that holds the meniscus down to the tibial plateau is right there. You will not be able to necessarily palpate, I feel that ligament, just know that it's there, and if that ligament has been strained any way, it will be tender to the palpation, tender to the touch. So, medial and lateral epicondyle coming off the femur down onto the tibia. You will feel the tibial plateaus. From the tibial plateaus, we will come to the midline and down. You will feel a natural, obvious bony landmark on the anterior tibia, and this is called the tibial tuberosity. Coming up, angling back up and lateral, superior and lateral, that actually forms into the tibial plateau will be a big tubercle on the lateral side called Gerdy's tubercle. This is basically the major attachment on the tibia from the IT band. The IT band comes across the knee joint and attaches to Gerdy's tubercle. Coming to the anterior surface of the patella, we want to be able to palpate the full edges and borders of the patella, the base being at the top or superior aspect of the patella, the medial and lateral borders, and then we try as best we can to palpate the apex. It is best palpated if we put our hand and tilt the patella like that so that we can better palpate the apex of the patella. So it's best palpated by pushing on the base of the patella so that the apex pops up and we can palpate the apex of the patella. From the apex of the patella, we can go straight in between the apex of the patella and the tibial tuberosity and palpate the patellar tendon, or some people call it the patellar ligament. And we have the patient contract their quads contract these muscles by pushing the back of your knee into the mat for me. And then we can actually palpate. Now this is a huge flat ligament. It is about an inch, inch and a quarter wide on most people. And we want to be able to palpate that full patellar tendon if we are going to do modalities or iontophoresis, soft tissue, cross friction on that patellar tendon. From that point, we will go to the lateral collateral ligament. I'm going to show you a quick trick. If you are having a hard time finding that lateral collateral ligament, is you can have the patient cross their legs, and it is much easier to find. It really sticks out like it's about the thickness of a pencil, small pencil, and it is a quite cord-like structure. Your osseous landmarks, of course, will be the lateral epicondyle of the femur and the lateral tibia, and that is palpated there. Now, you will not be able to do this with patients most of the time if they have strained this ligament. So if you just come in here and find your obvious bony landmarks of the lateral epicondyle of the femur, go just distal, and then you can palpate it, and it is cord-like. It is harder to palpate this way, but don't be discouraged. It takes a little practice. On the medial side, we will simply bring the medial knee and we're going to find our bony landmark is going to be the medial epicondyle. From that medial epicondyle, we're going to drop off into a gap, and we are going to follow from the tibial tuberosity, from the tibial plateau, around and around and around to where the tibial plateau disappears, and it disappears because it's a fan-like. Now this ligament is a fan-like structure and very flat, so you can feel the flat bands. It's a much wider ligament. So that's the medial collateral ligament. The next two ligaments are going to be not directly palpable, but they are going to be palpable through feeling the joint laxity. We are going to grab behind the knee with our fingers, and then we are going to place our thumbs at the tibial plateau and across the joint space. This will allow us to palpate any tibial movement, anterior posterior translation of the tibia on the femur. By doing that, pulling anteriorly, this is sometimes called the anterior drawer test, we can see the strength or integrity, palpate that integrity of the anterior cruciate ligament, the ACL. Conversely, we can push posteriorly and feel for movement from between the tibial plateau and the femur. With a posterior translation or displacement for the posterior cruciate ligament, or PCL. So as far as the ligaments, we have covered the ACL, the PCL, the MCL, the LCL, the patellar tendon, sometimes called the patellar ligament, and the coronary ligament that attaches the menisci to the tibial plateau.